Good morning, good afternoon, good evening to all our listeners across the globe. Welcome back to our webinar series on emittance audiometry. We have already covered in the past about tympanometry, high frequency tympanometry, multi-frequency, multi-component tympanometry, and also covered in detail about the fundamentals of acoustic stapedial reflex and reflexometry. We've also covered wideband absorbance and or reflectance in our last webinar by Dr. Srividya and Dr. Venkatesh Aithal. Today, we are going to cover the next topic, which is electrically evoked stapedial reflex, which is like doing our normal stapedial reflex threshold audiometry, but there are some nuances in it. And we are also going to talk more about wideband absorbance and also how all these things relate to cochlear implant assessment and mapping and stuff like that. So today I'm delighted to introduce to you Dr. Aniket Saoji, who is the director of cochlear implant section at Mayo Clinic in Rochester, Minnesota from the US. His interests lie in cochlear implant mapping and psychoacoustics. He has done immense amount of research into psychoacoustics and electrophysiology of cochlear implant recipients and also on electrically evoked stapedial reflex thresholds. Dr. Aniket, over to you.
Hello, everybody. My name is Aniket Saoji. I am the director of the Cochlear Implant Program at Mayo Clinic. Today, I'll be talking about wideband absorbance, eSRT, and cochlear implants. First of all, let me start by thanking the organizers of this platform and ISHA for giving me an opportunity to talk to you. I hope you all, wherever you are doing well, and your family is doing well, and you are staying safe and healthy, because these are just some unusual times and circumstances that we have not seen before. So we wish you all the best and stay safe. This is a disclosure slide because Mayo Clinics asked us to put in a full disclosure wherever we present, whatever we present. I'm actually a student of All India Institute of Speech and Hearing, Mysore. I did my BSc and MSc undergraduate and master's degree long time ago from Mysore. Did my PhD in psychoacoustics from Buffalo, New York. And after that, I spent about 11 years with Advanced Bionics and 2 years with Phonak in their research divisions. I currently have research support from Advanced Bionics and Cochlear Corporation, and I'm a consultant for Advanced Bionics and Envoy Medical. Envoy Medical is a middle ear implant company that has started work in developing a fully implantable cochlear implant, so nothing will be visible from outside. Envoy Medical is pretty close to doing first human trials of their fully implantable device, and the trials will be done at Mayo Clinic. And I was recently added to their advisory board member, so that's the latest addition in my disclosure section. Cochlear implants probably does not need an introduction today, but I'll quickly start by saying that in cochlear implants, we all know that there is an external piece and an internal piece, and the internal piece consists of a cochlear implant and an intracochlear array that is placed in the inner ear. The intracochlear array can have anywhere between 12 to 22 electrodes across 3 different manufacturers that are approved for device sale in the United States. So when we first start fitting a cochlear implant patient, we measure their T levels and then C levels or M levels or MCL levels, depending on which manufacturer we are talking about. So here a screenshot of a map that is created using the Advanced Bionics fitting software called Soundwave. On the top here are the 16 electrodes that are placed in the cochlea. And these up arrows at the bottom here are called as the T levels. That is the lowest current on each electrode that produces an auditory sensation. On each electrode on the top, there is this other line of down arrows, which is called as the M level, which is the most comfortable loudness level. And the clinician after measuring the T level, increases the current further and measures something known as the M level. And so here is the M level for each and every electrode. The same thing is done for a medal in a medal fitting software where there are 12 electrodes, or for the Cochlear software using custom sound, we fit this C level. Each of these levels, by the way, are in different units, and we'll come to that in a little bit. So how is this typically done? Well, we place a chart in front of a patient, assuming that the patient can provide us some feedback about loudness or use some loudness judgment. And thus we use a very simplistic approach, like, no sound to just noticeable, barely audible, very soft, comfortably soft, but soft, comfortable but soft, and most comfortable, and then too loud. So we put a scale like this in front of a patient. We start increasing the current, and we ask the patient to point us to level 6. Some clinicians like to go up or to level 9, maybe 10, 9, and then come back to 6, just so that they know that that's a very good, comfortable level. So essentially an outcome, a clinical map done in a traditional way, is the outcome of two personalities. One is the clinician and the other is the patient. A clinician like me is very aggressive. I don't really rely much on the patient's judgment. I like to go all the way to 9, maybe 10, and then I might even leave it there sometimes. Sometimes I come back to 8. I rarely stop at 6. There are other clinicians, my colleagues, who will stop at 6 means 6. They are more worried about the patient being exposed to intolerably loud sound. Each of us have different fitting philosophies. Not only each, there are some centers that fit more aggressively, and then there are some centers that fit less aggressively. What do I mean by that? Across clinicians, if you take an average, the M level here might be slightly higher or slightly lower across clinicians or across centers. And that's just a different fitting philosophy. My fitting philosophy is, when I fit a cochlear implant patient and I switch on the speech coding strategy, so it comes out to be very loud. And I tell the patient, just wait there for a minute. Your system's going to adapt, right? Every system adapts. Even a normal hearing system adapts to a loud sound. And we are dealing with an impaired system in cochlear implants, so there is huge neural adaptation. Sometimes what is level 6 on this chart in a 2-minute time frame or 3-minute time frame comes down to level 4. The patient doesn't realize that and never increases the volume on his own or on her own, but that's what happens. So that's why I like to map somewhere around 8, so that when all is said and done, the patient can comfortably hear at 6. Another aspect to consider, which is not documented heavily, is the following. In the morning, what is level 6, in the evening may actually be level 4. And that's because we, or even a normal hearing listener, encounters fatigue. Every evening when I start driving back from work, I crank up the stereo in my car. And the next day morning when I get into the car and that loud music comes on, I question, like, wow, I was listening to that loud music last night when I was driving back home. So we all undergo fatigue, and we need more loudness towards the end of the day to hear better. Now, hearing at different loudness levels is not a big challenge for normal hearing individual, but it is a challenge for cochlear implant patients. So coming back to this AB map, this is a map where T levels are down here and then M levels are here. Now AB sometimes says that the T levels, you don't need to measure T levels, and that's fine. We are not going to get into the argument of the fitting philosophy here. But this is how a typical map in the advanced bionics device looks like. And even if I were to measure T levels, they would be somewhere down here. Here is an example of a cochlear map. And here is cochlear C level, which is more or less similar to the M level without getting into too much controversy. But look at the T levels, right? The T levels are not down here somewhere like the AB device, but the T levels are up here. And a typical cochlear dynamic range is about 40-50 clinical levels. So this is a different unit. Here it's clinical units, here it's clinical level, and they ultimately all map to microamperes or amperes of current. So there are different fitting philosophies. There are different personalities at play here that are mapping the patients. There are patient personalities. Some patients are more conservative and are scared to go up in level. Others want to experiment more. And then there are different manufacturers which all do things slightly differently. So how do we know what is going on? Okay, so let's take a step back and find out why is there a difference between the AB map and the Cochlear map. I did intentionally ignore Medel from this presentation. That's because I don't want to make this as a comparison between the three different mapping functions or the three different speech coding strategies. I just want to use this as an example to say, why is there variability and why is it important to control that variability, and then what can we do about that variability in how we map our patients. So this is an example of an AB mapper. Okay, what do I mean by an AB mapper? On the bottom panel here is the current in clinical units, which is the same current that is shown here. Okay, but there is only one unit of current, and that is amperes, or rather in our case microamperes, because we use a very tiny amount of amperes worth of current for electrical stimulation. So AB has what we call as a linear map. So if I look at the 200 point here, or I've shown some numbers here, that corresponds to, sorry about that, that corresponds to 868 microamperes worth of current. And if I go down to 100 microamperes, 100 clinical units now, it corresponds to 434 microamperes. So from 200 to 100, there is roughly halving of current, which is how it should be, right? And that is a very linear map, and that is okay. Cochlear, on the other hand, has a slightly different fitting philosophy, and they have a mapping function that is more or less exponential in nature. What do I mean by that? So if I look at the number 200 clinical levels here, it corresponds to 648 microamperes. But if I look at 100, it is only 107 microamperes. So in the Cochlear device, the way I think about it when I'm fitting a patient is every 40 clinical levels. So for example, if I go down from 200 to 160, it is 315. So roughly half of 648 microamperes. Okay, and that is what this exponential function here looks like. So in the AB device, if you actually go down by half, the current level also decreases by half. In the Cochlear device, if you go down by 40 clinical levels, the current actually decreases in half, or if you go up in 40 clinical levels, the current actually doubles. So 1335 versus 648. So when I am fitting a Cochlear patient, I'm always thinking about 200 clinical levels is 648 microamperes. Now, because of this shallow growth here, you see that the T levels are generally much higher on this screenshot here while fitting a Cochlear patient. And then the M levels are closer to the T levels, and the effective dynamic range shown on the screen is roughly 40 to 50 clinical levels on an average. Whereas in the AB software, the electrical dynamic range is huge. Okay, and the T levels are generally closer to somewhere between 20, 30, 40 clinical units, and the M levels are somewhere around 200, 300, maybe sometimes 400 clinical units. Now, every time I see a patient and somebody else sees the same patient in the next visit and so on, we all write in our notes that we increased or decreased the SLE levels slightly. Well, we are all professionals. What do slightly mean? If I increase that C level by 10 clinical levels here, I have increased the input current to the cochlea by 25%. That's a big change versus an AB map, where if I were to increase it by 10 clinical levels, it's not that big of a change. It's not that big of a deal. So the mapping is very different, and small changes in one system may not mean small changes in the other system. And so, fine, I mean, so let's keep this in mind, that we have to be sure about how it's all mapped. And the second thing is, okay, fine, I mean, we measure this M level, and here is an example of an M level in a patient, okay, slightly different profile. But what difference does it make if it's slightly up or slightly below? Okay, well, we did the below experiment because we didn't want to go too high in level and have the patient be listening to a very loud sound and uncomfortably loud sound. So we said, okay, let's take this patient, for example, and decrease the M level globally. So we take all these down arrows and bring them down by 15%. So let's say this is the way I fit, and then my colleague decides to fit the patient 15% below the M level because he or she believes that that's the comfortably loud level for the patient. And then let's take another extreme example where we bring this M level down to now 30%, okay? And see what happens to speech perception, because this is a control study. We can systematically measure what would happen if I were to underfit this patient. Again, I am assuming that this is the best fit. Somebody might say, no, this up here is the best fit. So we just don't know what is a best fit and what is an underfit. And then there can be a case of an overfit. We do see sometimes patients who are way overfit and have poorer performance, and in those patients we bring the levels down and they perform well. Now there might be multiple things going on, compliance limit, all of that, and some of that I'll discuss in the next few slides, but some of that we'll leave it for next presentation sometime. So here is the speech perception score. This is a paper under review, and so I just took the figure and pasted it here. All these graphs here are in a quiet condition. That is, the speech is presented at 60 dB SPL presentation level in quiet. In the US, we use the AZ bio sentences and percent correct words on the y-axis. And all these graphs here are for the bars here are for the multi-talker babble condition. I used either plus 10 or plus 5 dB signal to noise ratio to avoid floor and ceiling effect. So this is the baseline condition which we consider the patient's clinical map. I am going to request the audience to ignore these two bars here because those are conditions that I'm not covering in this presentation. And this is what happens when I decrease the M level by 15% and I decrease the M level by 30%. So about a good solid 20-30% decrease in speech understanding, and it's variable across subjects. The effect in noise is slightly more dramatic. This is the baseline condition, 15% lower M levels and 30% lower M levels, and you can see a decrease in score. One could argue that maybe if I fit the patient even more aggressively, this bar may go up further. Possible, we haven't explored that condition. So this tells you that underfitting the M level or the C level can have significant impact on speech perception and in quiet as well as in noise. So why is that happening? So here is an example of a spectrum which has some peaks and valleys and peak and valley and so on. And the crest factor is about 25-30 dB. That means the peaks are 25 to 30 dB above the valley and so on. So here is a mapping function of the advanced bionics device. 60 dB SPL sound is mapped to M level. Now, those of who are familiar with the exact implementation and architecture of the device, I agree the point that is mapped to M level is 63 dB, and the sensitivity of the microphone influences that. I have just overly simplified the mapping function for our audience today. So 60 dB SPL corresponds to M level of the device, and then T levels is somewhere down here. So if I were to take this point and assume this is 60 dB and that valley is 30 dB, then 60 dB maps to M level, and then 30 dB will map somewhere halfway into the electrical dynamic range. So essentially we would represent it with the electrical spectral contrast, or let's say represented by alphabet A, okay? Now, if I were to simply decrease the M level by 30%, then my 60 dB will again map to my 30%, but my 30 dB sound moves on lower only by slightly. And so that's what it would be, somewhere half of this electrical dynamic range. And that would essentially decrease the spectral contrast, which is shown by alphabet B here. So if we do not push the limit within some certain boundaries, we are potentially going to underrepresent the spectral contrast. And we all know that that spectral contrast is important for speech perception, not only in noise, but to a certain extent in quiet as well. And so this is the consequence of underfitting M levels or C levels or MCL levels in cochlear implant patients. So that means there needs to be an objective method that will guide the clinician to say what I have done is correct, or what you have done is correct, or at least you are in the ballpark. You are not way off, or you are not way over than what is a true M level in cochlear implants. And that's where we have eSRT come into the picture. eSRT is nothing but an electrical stapedius reflex threshold. You all are very familiar with SRTs, and especially the recent presentations would have really given you great insight into your into what is eSRT and how what is SRT and how it's measured. When I'm using the acronym SRT, I'm referring to stapedial reflex threshold. So eSRT is a slightly modified version of that, where instead of using an acoustical stimulus to elicit the reflex, we are using an electrical stimulus. We are obviously bypassing the external ear, middle ear, and the inner ear, and we are sending the electrical stimulus directly to the nerve, and everything else is then more or less similar. It goes through the cochlear nucleus, olivary complex, comes down through the facial motor neuron, and then stimulates the stapedial tendon and muscle. eSRT, I can simplistically define it as the lowest electrical stimulation level that elicits a measurable contraction of the middle ear stapedius muscle. In a normal hearing ear, reflexes happen somewhere around 80, 90, 100 dB, and so it's reasonable to say eSRTs will also happen at 80, 90, 100 dB sound presentation level. However, there is no dB, it's all microamperes or clinical levels or clinical units, and they will roughly correspond to the upper limit of upper bound of electrical stimulation that is advisable for a cochlear implant patient. So that's the analogy, 80, 90, 100 dB SPL sound elicits a normal reflex. Roughly the same amount of loudness in the electrical domain will also elicit an electrical stapedial reflex, and then that can be then used to set M levels or C levels or MCL levels in cochlear implant patients. So you all know the reflex arc and everything, but I just wanted to show you an eSRT that we measured in the OR. Here is the electrode array that is already being placed in the cochlea. So the electrical stimulus is being delivered through the electrode array. And I am going to draw your attention. So this is the stapedial tendon that is visible. And I want to draw your attention to this white dot here on the stapedial tendon. And you will see it move as soon as I play the video here. So I'm going to play it again and then point to it when it actually moves, because there is some jitter right there. I don't know if the video on my screen is not playing smoothly, so I don't know how smooth it is on your screen. Right.
You can make it out.
Okay, good. So that's the stapedial reflex. The very first time I saw it in the OR, I developed a great deal of appreciation for this teeny tiny tendon that is doing all the work. Pretty interesting. So in cochlear implants, we have the opportunity to measure what is called as visual eSRT if you are in the OR and the surgeon is monitoring through the microscope, and you can present the stimulus and so on. And then of course we have the impedance based eSRT. And in an impedance based eSRT, things are done slightly differently when measuring eSRT, and that is we don't have a time logged electrical stimulus and a measurement window like we usually have in a GSI or Titan. So what we have to do is either put the measurement system in a reflex decay mode so that it will run for a few seconds, or Titan has an eSRT mode where it just simply keeps running. It's measuring reflex or change in admittance, impedance, whatever we want to call it, and it just is measuring it all the time. Okay. And then we present some burst of stimuli, the same burst of stimuli, that electrical stimuli that we use to measure M or C levels. And here what I've done is I've presented 3 bursts of stimuli that are 500 milliseconds in duration each. And otherwise you see there is a lot. So I measured some reflexes before, then there is some noise in the measurement. Here is some patient movement. Again, some noise in the stimulus. Then now these are the 3 bursts, and that's the reflex. And then of course there is some noise again. This is done using a slightly different pro frequency than 226 Hertz, and we'll come to that in a little bit. So one of the things is it is not as sophisticated as some of the time lock measurements are when we measure reflexes. And we have to make sure that all this noise that is going on in the back, the reflex has to stand out from that. Okay, because if the reflex doesn't stand out from the noise, then we won't be able to visually see it. So there, all the denoising, smoothing. I mean, not a lot of that is actually happening in the reflex decay mode, that in the way we are using it for measuring eSRT. So that just slightly different things in eSRT. And then one of the other things that I thought I'll just throw it in here in the middle of this presentation was, eSRT, or sorry, SRT has this. We present the stimulus, it has to be at or generate a certain level of loudness, and then we measure SRT. Well, if we measure the same SRT with our eyes closed, when our eyes are closed, our auditory system automatically increases the loudness of the same stimulus that was presented when the eyes were open. And because the loudness increases, the stapedial reflex threshold is about 3 to 4 dB lower than what it would be with eyes open. This happens in a normal hearing person also, so maybe we can try it on ourselves also. Of course, we have to measure eSRT in 1 dB stats. So that tells you that it's all just a loudness dependent phenomenon. It is, you present a stimulus, if it generates certain level of loudness, it will elicit a measurable stapedial reflex threshold, which again has some consequences of, when we are measuring eSRT in the OR, when the patient is asleep and is under anesthesia, what is that going to do and predict levels and things like that. And I'll talk to it briefly about it in my presentation. So while measuring eSRT, everything that we do for measuring SRT has to be followed, right? Tympanometric peak pressure and seal and all of that. That all you know better than I do, to be honest, because I don't measure eSRTs every day. I don't know if I really fall in the camp that totally relies and believes in eSRT, and we'll discuss some of that. So in my opinion, in the cochlear implant field, there are two types of clinic: a clinic and a clinician that lives totally by eSRT. If they measure eSRTs, they are very much at ease and see tremendous value in it. And then there is this other camp which once in a while measures eSRT, if at all needed, and really questions what the eSRT is telling us. And these two camps are really very different and have very different thought processes, and we will think about it in a little bit. So one of the most important things on the stimulation parameter side to consider is the stimulus duration. We have had difficulty. I'm not going to take any specific names of manufacturers, whatever. A lot of times I get into trouble for doing that. So I'm just going to say that sometimes I've measured reflexes using a 250 millisecond burst of pulse train. Okay, in the electrical domain, we use biphasic pulses for stimulation. And so if I use a 250 millisecond burst, then sometimes we do not get a reflex, even if I try to push the level as hard as I can. And I fit sometimes very aggressively. So even then we cannot measure reflex. But with 500 millisecond, we can measure reflex in the same patient very easily. So stimulus duration plays an important role while measuring electrical stapedial reflexes. There could be potentially two causes of that. One is in normal hearing, the temporal integration window is 200 milliseconds roughly. What do I mean by that? A 1000 hertz pure tone stimulus presented at a 60 dB SPL generates a certain amount of loudness. But the same stimulus presented for less than 200 milliseconds, let's say presented for 100 milliseconds, is about 6 dB softer, or is it 3 dB, 3 or 6 dB softer than the same stimulus that is presented for 200 milliseconds. Because the auditory system accumulates the stimulus over time for at least up to 200 milliseconds and kind of keeps adding to the loudness. increasing the stimulus beyond 200 milliseconds doesn't seem to particularly affect the loudness of that stimulation, and that is called as temporal integration or temporal integration window. In cochlear implants, in some patients, in some electrodes, over time or whatever it is, the temporal integration window may be greater than 200 milliseconds, and the reason being poor neural survival. So the other aspect being, see, we are not time locked. We don't know when the stimulus is being presented, and we don't know when the measurement is done. So these two are unlocked events. So here is that reflexes that we measured, these three bursts of electrical stimuli that we presented. If the sampling were to happen at only these 3 or 4 points, I am not sure that this measurement here would be any different than the random noise that we are seeing while measuring the reflexes. So this sampling might be important, and so that's why we might need a longer duration of the stimulus, because if we use a 200 millisecond stimulus, we may sample poorly and then it may not look like a reflex. Okay. The other thing is compliance limit. Sometimes the compliance is being monitored as we increase the loudness level. Sometimes it is not. And if you exceed the compliance limit of the medical device, I mean the cochlear implant, we'll see what happens here in the slide. So here is a patient, let's say, who has 5 kilo ohms impedances, and we pass in 400, 600, 800, and 1000 microamperes of current, and you see this nice biphasic pulse, cathodic anodic biphasic pulse that increases in amplitude. Here is a patient, let's say, who has 10 kilo ohms impedances, and too bad my scope, I should have adjusted my plot here, but sorry about that. But here is what happens: 400, 600 increases, then we have 800 increases further. At 1000, it is clipped. So V equals IR, it's the Ohm's law, right? V is compliance voltage, R is the electrode impedance, which is shown here in kilo ohms, and then I is what is maximum allowable. So if the impedances are high, let's go to the next slide. So here is the compliance voltage of 8 volts. If the impedances are low, you can push in a lot of current. See the amplitude of the pulse here. But if the impedances are low, then you can push in only so much of current, right? So in this patient, then what you have to do is increase the pulse duration to actually achieve more loudness. So it is important to know that we are not exceeding the compliance limit or the compliance voltage of the device, because even though on the screen the current appears like the current is increasing, behind the scenes what the implant is doing is the biphasic pulses are clipped and there is not much growth in loudness happening. Here is I just wanted to show you the device that is used to make all these measurements. Here is a reference implant from Advanced Bionics that is connected to resistors that are 10 kilo ohms. So that is used to simulate a 10 kilo ohms electrode impedance. And then out of a BNC cable, you can stream out of the 16 independent electrodes. And this is the headpiece cable, assuming. So this more or less acts like our dummy patient, and we can look at the output of each individual electrode. So that comes down to the stimulus parameters. We have to make sure that these two things are taken into consideration while measuring reflexes, and then recording parameters. And ipsilateral versus contralateral eSRT. Now, when I say contralateral eSRT, I'm assuming that this patient is unilaterally implanted, because ipsilaterally we know the patient has had middle ear surgery. I mean, a facial recess was drilled, implant was put, the electrode array was inserted in the cochlea, so it is all happening through the middle ear. And so ipsilaterally, sometimes measuring reflexes is difficult. Contralaterally, on the other hand, if the patient is implanted only in one ear, the contralateral reflex measurement is easier because that ear does not have any surgery done. Of course, you have to worry about the age, possibly some kind of otosclerosis and things like that that may prevent us from measuring reflexes. The same things that would affect a normal reflex would also affect an electrical stability. Now, in cochlear implants, it is typically recommended that instead of using 226 hertz, we use a higher probe tone frequency, such as 678 hertz and 1000 hertz. And we have a publication on it. in the US, I was just talking to Imran, and in the US, he said that that's not widely used. But I'll say that in the US, if I talk to Renee Gifford or University of Miami or NYU, I think we all use a higher probe frequency, such as 678 or 1000 hertz to elicit reflexes. And I think across the board, everybody will say that we have a better chance of successfully eliciting a reflex with a higher probe tone frequency versus a lower probe tone frequency. Now, this is unique, right? This is not been reported in the acoustic world. And correct me if I'm wrong, but I have not read that there was a patient or a normal hearing person in whom we could not measure a reflex using a traditionally used 226 or 220 hertz probe tone, but we were able to measure reflexes using 678 and 1000 hertz probe tone. What happens, I would say, pretty routinely in cochlear implant patients, especially in the ipsilateral ear, in the ear that was implanted. So a lot of times, a lot of publications are done where eSRT is actually measured in the contralateral ear, not in the ipsilateral ear. So okay, now we have figured out, what can we do to maximize our chances of measuring eSRT or successfully measuring eSRT. And there is so much literature out there that there is no doubt that when we measure eSRT, it predicts the comfortably loud level, or C level, M level, whatever we want to call it. Most of these studies use a single electrode stimulus. So what do I mean by that? Sorry, I'm toggling back and forth here. But so that means we present the stimulus on this electrode 1, we measure eSRT. Then we present the stimulus on electrode 2, we measure eSRT. Then we present the stimulus on electrode 3 and we measure eSRT. Now, from our fitting experience, we know that if we measure comfortably loud level, behaviorally comfortably loud level on each electrode and switch it on, it is going to be very loud to the patient. We have to measure the M levels or C levels on individual electrode globally, then decrease the level and then switch it on. Otherwise, it's going to be pretty loud. And I sometimes say the patient is going to jump out of the chair, because together when we stimulate these 16 electrodes, even though they are pulsatile stimulation, they are going to be louder than by each electrode by itself. So then the question is, yes, I can measure eSRT. I can measure eSRT using individual electrode, and I can say that is the comfortably loud level. However, I cannot use that level readily in a speech coding strategy. And then the question is, can eSRT spread comfortable loudness levels that I can just measure and just drop it in and switch on, right? Because once I measure eSRT, and if I have to use my judgment to make global adjustments to that map, what's the point? Because we just saw that slight changes to in M level or C level can lead to large changes in hearing performance. So here is a study that we did in Cuba when I was employed with Advanced Bionics, where we compared Advanced Bionics' 3 modes of stimulation. One mode is tone burst, where a single electrode like the one shown here, electrode 3, is stimulated and we measure a reflex. Advanced Bionics also offers a speech burst mode where 4 adjacent electrodes are stimulated in a sequential manner. Okay. And then we designed a mode called as all electrode mode, where we stimulate all the electrodes in a sequential manner. Now, this mode is more closer and similar to what would happen in a speech coding strategy, and we'll come to that. But tone burst is 1 electrode stimulation, speech burst is 4 electrode sequential stimulation, all electrode is 16 electrode sequential stimulation. And this is similar to using a pure tone, narrowband noise, and a broadband noise for electrical stimulation, right? Or in acoustical stimulation. And so this is the electrical equivalent of pure tone, narrowband noise, and broadband noise in electrical stimulation. So as you can see, we measured on electrode 3, electrode 7, electrode 11, and electrode 14. And for individual electrodes, oh, by the way, this is data from 9 patients from S1, subject 1 to subject 9. So each panel represents data from 1 cochlear implant patient. X-axis is the electrode number, Y-axis is the eSRT in clinical units. So let's take this patient in the Madhu. Individual electrodes eSRT is higher than the speech burst. Pure tones would be higher SRT than narrowband noise, just like it's shown here. And then we use all electrode stimulation, the eSRT is lower. So if I take this case, then the eSRT is, I think, 240 versus 200 versus 160 clinical levels, right? Huge difference between how many electrodes are stimulated or are used to stimulate and to measure eSRT will determine where the eSRT falls. So once we measured these eSRT levels, we said, let's go back and correlate those eSRT levels with the patient's map. These are all adult patients, actually in their 20s, 30s, young adults who are very enthusiastic to participate in the study. And so we compared these levels with the M levels from the patient's clinical map. So M levels is shown on the X-axis here. eSRT is shown in clinical units on the Y-axis. And you can see that so the way to interpret this plot is if all these symbols for the 9, 10, 9 cochlear implant patients were on this diagonals, that means the M levels sort of one-to-one correlations with the eSRT levels, right? But what is seen here is when we use tone burst on electrode 3 and tone burst on electrode 7, the tone burst eSRT is significantly higher than the M levels that are used to stimulate from the patient's clinical map. Not too surprising, right? Because if you measure eSRTs on individual electrodes, they're going to be significantly higher than stimulating all electrodes sequentially. More or less the same thing happens with speech bursts, where we stimulate electrode 1 to 4, electrode 5 to 8, electrode 9 to 12, electrode 13 to 16. They are still higher than the M levels. Now, when we use all electrode mode, we are closer to the diagonal. But remember, we are still not right on the diagonal, but we are closer. So if you simulate all the electrodes sequentially, more or less what one would do in a speech coding strategy, then we have a good chance that most of our electrodes are going to be closer to the real M levels from a speech coding. The eSRT levels are going to be closer to the M levels from a speech coding strategy. So really the stimulus that is used to measure, so what this tells us that the stimulus that is used to measure eSRT should mimic more or less the speech coding strategy that is used to make the eSRT speech coding strategy that is used in a routine clinical map. So what do you mean by a speech coding strategy? So here is an example. So advanced bionics, as you know, has a sequential and a paired speech coding strategy. Whether it's Optima, whether it's Fidelity 120, they use a sequential map and then a paired map. So here is a frame of a sequential map. In advanced bionics device, in a sequential map, electrode 1 and 2 are stimulated first together, and depending on the proportion of the current between 1 and 2, they generate this current steering, intermediate pitch, and all of that. But electrode 1 and 2 are stimulated first. Then electrode 5 and 6 are stimulated. Then electrode 9 and 10 are stimulated, and then electrode 13 and 14 are stimulated. And then this follows, and then this frame repeats itself. Each phase has whatever pulse width that we decide or we fit the program with, and that is how electrical stimulation is done. Okay, this is the sequential mode. Let's come to a paired mode. Okay, in a paired mode, at the onset, electrode 1 and 2 are stimulated simultaneously. So electrode 1 and 2 are stimulated simultaneously, and at the same time, electrode 9 and 10 are also stimulated. There are these parallel speech coding strategies, and then there is a philosophy behind it. I'm going to keep the philosophy. I'm going to try to stay away from the philosophy today, but this is how a parallel stimulation is done. It's more or less done the same way in the Medell speech coding strategies. I'm not going to make this about a speech coding strategy. I just want to briefly touch upon these two speech coding strategies to say, how do we circle back to eSRT? Because if I'm fitting a patient sequentially versus I'm fitting a patient in a paired mode, I have to be doing something different when I take the eSRT levels into consideration. So that's what I'm trying to talk about here. So electrode 1 and 2 and electrode 9 and 10 are stimulated simultaneously. Then there is some gap here, some pause. There is no stimulation there. And then electrode 4 and 5 are stimulated simultaneously, and along with those are stimulated electrode 12 and 13. And then a pause, and then another pairs, and then so on. So what happens in the cochlea is electrode 1 and 2 generates an electrical field. Electrode 9 and 10 generates an electrical field, and then depending on the spread of the current, these two electrical fields actually sum. That's why when you go from sequential to paired, if you take somebody's sequential map and just convert it into a paired map, the sound wave pops a message saying the stimulation levels can be loud. And that's because this current and this current is going to sum to a certain extent. In some patients, it's going to sum by a lot. In other patients, it's going to sum by a little bit. That just simply varies on the placement of the electrode, anatomy, neural survival, all those things. So that's going to be a difference between a sequential and a paired strategy. So if I measure an eSRT using all electrode stimulation in a sequential mode and apply it to a patient who is using a paired speech coding strategy, this is exactly what I'll see. All our 9 patients were using a paired speech coding strategy. And that is why you can see that the eSRTs in a sequential mode are slightly higher, and that's because most of them are above the diagonal than the M levels. And that's because eSRTs were measured sequentially where there was no peripheral summation of the current in the cochlea like it would be happening in a paired speech coding strategy. So essentially what we did was we used this kind of a stimulation paradigm to measure eSRT, but ended up stimulating the patient this way. And that's why there is a difference between eSRT and M levels even after using all electrode stimulation. In a cochlear device, for example, what would happen is something like this. Instead of 15 slots, there would be 22 stimulars in 22 slots. There is not going to be any current steering. There's going to be single electrode stimulation. But out of the 22 slots in any given frame, we will only be stimulating, we will only be presenting 8 biphasic pulses. That's called the N of M strategy. Now, of course, you can increase the N or the spectral maxima, and then depending on the N, you will end up stimulating those many biphasic pulses. So what I'm trying to say is, it's not just that we measure eSRTs and we can predict the M level. The number of electrodes used to stimulate the eSRT matters. And then at the end, it also depends on the speech coding strategy that we are using. So given all of this into consideration, eSRT gives us a ballpark estimate of where we fit the M and C levels. It is not a number that I can just readily plug in and say, yep, this is the perfect M level, and this is how this is how every patient should be fit. We derive a lot of comfort when we measure eSRT and we map the patient. I think we all believe that we are in the ballpark and it's correct, but it's not the M level that every patient should have. There are still some changes still some modifications made to those levels to achieve comfortably loud levels in a cochlear implant patient. But it gives a good confirmation, especially in patients who cannot provide any feedback, children especially, where eSRT can be used to map cochlear implant patients. So that was eSRT. And again, we need to talk about the pro frequency, which I'll cover in the wideband tympanometry part. So coming to wideband absorbance. I'll be upfront very honest. I have very limited understanding of wideband tympanometry. And now I'm working with the R&D folks in interacoustics and things like that. I'm trying to reach out to them and learning a little bit more. But I have very limited understanding of wideband tympanometry. So folks on the call here will know more about wideband absorbance and tympanometry than I do for sure. But why did I even decide to go this route? Okay, here is a patient who has this kind of hearing in the right ear shown in the red, and then left ear is this kind of a hearing loss. And this patient was implanted at Mayo Clinic. And then, of course, we want to save all the residual hearing. This is a child, by the way. This patient was implanted, and post-implantation, this is what happens. The bone conduction improve a little bit, and the air conductions decrease a little bit. If you go through the cochlear implant literature, there are patients developing a new conductive hearing loss after cochlear implantation that is not there before these patients undergo cochlear implantation. And in today's day and age, where we put in tremendous effort in trying to preserve residual hearing, this conductive hearing loss kind of, just spoils the party, I would say, because we try to preserve hearing, and then there is this new conductive hearing loss, which we don't know much about. Now, in this patient, we have both. The bone conduction is improving and the air conduction is decreased a little bit. In some patients, we only see the bone conduction improve, and in some patients, we only see the air conduction decrease. So, what is going on in these patients? Obviously, we have a middle ear surgery. I mean, we have a cochlear implant surgery, so that must have done something, and that most likely will lead to a decrease in air conduction thresholds. But then, how do we explain the improvement in bone conduction thresholds? And one of the questions you may be asking is, did we mask enough? Well, we masked the heck out of this system, and still we couldn't the bone conduction threshold. In fact, if I were to not over mask, if I may say that, these bone conduction thresholds would be 5 dB or 10 dB even better. But anyways, so the literature is full of these reports now where there is conductive hearing loss after cochlear implantation. So we start looking at the literature, and here is a nice summary of VEMPs. And VEMPs is used in this superior semicircular canal dehiscent patient, in whom we can sometimes see an improvement in bone conduction thresholds, like we see here in a cochlear implant patient. And so if you now look at these VEMP results, they measured air conduction VEMPs in about 344 patients across all these many studies that are listed here. 227 patients had air conduction VEMPs. 117 patients had no air conduction VEMPs before surgery. This was done pre-operatively. Post-operatively, fewer patients had VEMPs present, more patients had VEMPs absent. And the immediate conclusion at that time is, likely looks like the cochlear implant surgery is causing some vestibular trauma. Well, I think there are now reports showing that bone conduction VEMPs are still present in some of these patients, and air conduction VEMPs are absent. So it doesn't look like it's all vestibular trauma. It could be the middle ear. So in trying to understand what is going on, we measured wideband absorbance pre-operatively and post-operatively. I think wideband absorbance is nicely covered last time in the presentation, so I'll keep this explanation to minimum. So here is our 226 Hertz tympanogram that we routinely use in the clinic. And I'm going to fast forward in the interest of time. And then here is the wideband absorbance pattern measured at the peak of the 226 Hertz tympanogram. And we compared that in patients before implantation and after implantation. So before implantation is this peak here is the black curve, and after implantation is the green curve. This is the unimplanted ear that was served as the control for each patient, and that's this pattern here. And in the implanted ear, this is the pattern here. And you can see a very dramatic shift in the peak. The resonance changes, although resonance is a different story, and it depends on your model. As good as your model is, only the resonant frequency is only as good as your stiffness mass and model is, and things like that. But the bottom line here being that the middle ear transfer function changes significantly after cochlear implantation. And a couple of these patients also show a decrease in air conduction threshold post-implantation. In the interest of time, I'm going to skip that. Okay, so you can see that the middle ear surgery or the implant surgery and placement of the electrode and everything have changed the middle ear characteristics quite a bit. And so this may be one of the reasons why now a 226 Hertz probe, to begin with, a 226 Hertz probe is much further away from the middle ear resonant frequency, which is normally between 600 to 1000 Hertz. And so using a 600 Hertz or 1000 Hertz probe, which is closer to the middle ear resonant frequency, has a better chance of eliciting a reflex or an electrical stapedial reflex as compared to a traditional used 226 Hertz probe. In fact, almost always one should use a 678 or 1000 hertz probe, because that is closer to the middle ear resonant frequency, and so measuring reflexes should be easier, or at least happen at a slightly lower level. But I think in the olden days, 226 hertz was readily available and was easy to implement technically, and then there were some limitations to implementing a 1000 hertz probe, and so I think we started using a 226 hertz probe, and we have stuck to using a 226 hertz probe. One of the research ideas, I mean, I really don't have much time to do research other than the research that I'm doing, but I have been challenged many a time saying, you know what, if you can measure a reflex at 678 hertz and 1000 hertz, you should be able to measure a reflex at 226 hertz probe. It may be slightly higher in level. You should be able to push the cochlear, the the stimulation level up, and may be able to measure a reflex at 226 hertz probe. I have been unsuccessful. I can push current very high in my patients, and my colleagues will tell you all stories about it. But that happens to be the case. I think one of the future research projects which can be undertaken by some of you is, you know, we have these SSD patients now who have normal hearing in one ear and like electrical hearing in the other ear, implants in the other ear. And you can now measure ipsilateral contralateral acoustic reflexes and ipsilateral contralateral electrical reflexes in these patients. And if one can measure a 226 hertz contralateral acoustic reflex in the implanted ear, but cannot measure an ipsilateral 226 hertz electrical reflex, I think that will tell us whether if the loudness is not just enough for the electrical stimulus, or if there is something totally wrong with our ability to measure reflexes using a 226 hertz probe. Thank you.
Thank you so much for such a wonderful and very insightful presentation, sir. We'll open the session for question and answer now. If that is okay, I can just go through the questions one by one, and you can see if you can answer them. Is that okay, sir?
That's fine.
Okay. So the first question, sir, is about the people who are blind, like you were talking about, you know, like when you close the eyes, the loudness improves by 4 dB. So I think somebody is asking, like, what happens in people who are blind?
Honestly, I don't know. If I may speculate, I would say that unfortunately people who are blind, who have developed blindness or are born blind, have an enhanced taste or smell or enhanced senses, I would say, and I would assume that their auditory system is probably more alert than an auditory system of a normal hearing person. That's just a speculation. Honestly, I don't know the answer.
Okay, sir. The next question, sir, is can we use electrically evoked stapedial reflex threshold to create map? If so, could you please elaborate the importance of eSRT over behavioral test for creating a map?
See, I think behavioral thresholds, if obtained, eSRT can be used to just confirm those behavioral thresholds. Now, what I did not get into was, you know, different types of maps. Sometimes we have patients who tend to underfit themselves in the high frequencies because they don't like to listen to those high pitch sounds and things like that. Sometimes the growth of loudness is pretty abrupt in the high frequencies. So we don't know what is going on. And then eSRT can be used to correctly predict the M level or C level in the higher frequencies. So I think behavioral measurements and eSRT are sometimes complementary to each other. Sometimes eSRT can take the lead, and then the clinician can use the judgment to globally adjust the levels as needed. It's just another tool in our arsenal to kind of make sure that we correctly map our patients.
Could I also add on to this?
Yes, ma'am.
Aniket, so great talk. Nice listening to you once again. This is Asha Yetiraj here.
Hello,
In
ma'am.
our clinical with mapping using eSRT, I think we get great maps. Actually, we've had a time when we had this one young boy who didn't like the louder sound, and he kept saying that he's demonstrating that he was having palpitations, and so we were scared, and so we brought down the levels then compared to what the ESRT values were. And then the clinician came back and said he's just not performing well with the map now. And then when we went back and set it back to the ESRT levels, he was definitely doing so much better in therapy. So I'm a great proponent of saying, yes, set the maps based on the ESRT, but I go totally based on the company. So for both the companies that you talked about today, Cochlear as well as Advanced Bionics, we don't use in our clinic eSRT at all, because they have provided us other tools which they say are better for them. And this is what we were taught. You work with AB, but the AB people have taught us to use NRI rather than ESRT. With metal, it's almost 90% of the time we've used it. We have always found it to be useful as long as we are getting good responses. And we find the amplitude varying so much from one patient to the other. Some of them we don't get at all. And the reasons, this is research that we have done, my colleagues and I at ISHA. We find that if the surgery is done using a Varia technique, quite often we don't get responses. We don't get eSRT responses. But when it is done using the mastectomy approach, and more often we are going to be seeing responses. So it depends on whether it is Varia. I'm not saying it always when it's done with Varia that we don't get it. A few times we do get it. And I think as a part of that surgical technique, they do tend to damage some structures in the middle ear. So depending on the surgical procedure that is done, you may or may not get responses. And this is taking from your message where you talked about saying stimulate all of the electrodes together and then you get a better response. I would like to add on over here saying we also tend to do groups of electrodes, but we don't recommend that you do all together. The reason why we don't recommend it is the thresholds are very different for the mid, high, low frequencies, and it's so very different. So you might be getting responses more from one set of electrodes rather than the entire lot. And so what we find is if we take groups like with AB, if we would have done it with 4. This is what we do with Digisonic. We take groups of 4 and we are doing it over there. And we get a curve that comes in, and that actually almost is like the not tonotopical, it's like the loudness curve of the signals that are going to be heard by the auditory system. So that makes it better. This is my own personal experience, and my colleagues over here, we are 5 of us who work together, and all 5 of us find that to be better that way. Yeah. So I do recommend saying that eSRT is a great way to set your maps.
Thank you so much for your input. Very much appreciate the thoughts here. One or two comments, if I may make. Of course, I'm talking to my professor, so obviously whatever she says has the authority over me, no doubt about that. I totally agree with you that eSRT is a great confirmation and a great fitting tool. One of the things that I did not talk about was Cochlear has this very nice feature. What is it? Soft start or soft start, where one can say over a span of these many seconds or minutes, gradually go up to the sea level. And so we have done these eSRT measurements and fitted our patients with that. And we have gone 25%, 30% more current past eSRT. Now, if we were to start with that stimulation, the patient will jump out of the chair, like I said before. But if we gradually increase this over a span of 2 to 5 minutes, there is so much adaptation going on that if I go well past beyond the eSRT levels, the patient can tolerate it. And some of those patients perform extremely well with this map than just the routinely done C-level map that we would have done with eSRT. So I think eSRT is a great starting point, but there is so much adaptation going on, especially because we have poor neural survival. In fact, one of the things that we are now started doing is measuring reflex decay tests to find out how much adaptation we have. And if the amount of adaptation changes as a function of pulse duration. I have anecdotal data, and that's why I didn't include it in today's presentation. Is if instead of using a 50 microsecond pulse width, I could use a 200 microsecond pulse width and have less adaptation, neural decay, or whatever it is over time, then it would that loudness will be sustained in that auditory system over time, and the patient will continue to hear or continue to perform better. So I think eSRT is a great starting point, but I don't know if we should stop thinking right at eSRT or maybe try to push the patient higher, or think about eSRT as in a slightly different way. And the second thing is I would like to add to your point that absolutely that using groups of electrode is better, because apical versus basal versus medial portions of the array might have different C levels. So one of the things that we did was we measured eSRT pretty much on every electrode. We made and so that was the eSRT profile that we got. And then we globally decreased the eSRT level to find the lowest level at which eSRT was generated. And that seemed to have worked just as well. So I think your point is well taken that we have to make sure that we get the profile of the eSRT profile first, and then make play with the level to get maybe a group of electrodes, an eSRT on a group of electrodes, or all electrode stimulation. But thank you so much for your input.
I'm sorry. Just like how you get for regular reflexes, the higher frequencies, a lot of times we need a lot more current to be able to elicit the reflex, or we don't get the reflex. So at such times, we actually don't use that value over there. We bring it down because we feel it is a phenomenon of the reflexes itself, which I think with those of us who listen to Ajit and was talking about saying, why is it in the higher frequencies you don't get such good responses? So we don't set the eSRT at the actual values in the higher frequencies. I'm just saying the opposite of what you said. There we would bring it lower. We don't go higher. And truthfully, this is majorly with metal cases that we have used eSRT and Digisonic. We never go above the value. We find our patients just are not able to take it. So a lot of times we actually bring it down, not go above the eSRT levels.
Right, I agree with you, ma'am, that we use the eSRT as the final limit. What I'm saying is, if something that is comfortably loud right at the get-go is not staying at comfortably loud levels over the next 10-15 minutes or so because of the because of long-term adaptation going on. And so
what we do for that, especially, I mean, this is for every patient, I'm sure in all clinics, you have progressive maps. So it doesn't matter which company, even if it's AB or any other company, we always have progressive maps. We follow the principle what Cochlear says, and we progress gradually to get to that level. But the point I'm saying, we go below the eSRT values and then get to eSRT values. That's how our clinic is doing, and our kids are doing good.
Okay. Have you experienced in your clinical practice patients saying that sometimes they have difficulty hearing as the day progresses? They've experienced fatigue, or they don't hear as well as they heard in the morning. Just curious.
And the trouble with our clinic is most often we have all of them are children. We don't have adults. And the older ones have not made this comment at all. So far, we've not had it. Actually, it's the other way around. They get very tired in the end of the day. So that's one thing that we've noticed. If we keep the MOC levels too high, and it tends to be too loud, and then they're tired in the end of the day. So it's like they don't want it louder. So even what you made a comment, actually, I was thinking about when you said, when you come back in the evening, you want your music louder. It's the opposite for me. When I'm coming back in the evening, I want my music softer. I'm so tired. I want something softer. So I think it's totally varying from one person to the other. In the morning, I don't mind the sound being louder because my energy levels are also high. And in the evenings, I want it softer because I just want to something soothing. So I think our personalities vary, and I suppose they're also to vary. I had asked Ajit a question when he presented. I'm going to ask you this same question. Where in most of our cases, when we do eSRT, when we're doing a descending technique, we are getting a lower value. And when we're doing ascending, we have to get, we have a higher value. And it's not just one patient. We've seen it over so many patients. This is majorly with Medal, not so much with other companies. But since we are doing it majorly with Medal, this is point that I've been noticing, and not just when I am doing it, when my colleagues are doing it also, they also observe the similar thing. So could you comment about that?
Yeah, and that's a phenomenon we see it all the time, and which is why it's one of the reasons I shy away a little bit from eSRT in the clinic, because ascending we get one value, descending we get the other value. If the best part is in the OR, I sometimes play tricks on our surgeons here, and we are joking while measuring eSRT and things like that. And even when they tell us, there is a range. If we start going in an ascending manner, we need a higher current for them to tell us that they see a visual contraction of the stapedial tendon. And from when we are descending, we go well below the ascending threshold to measure eSRT. I think it's just the way adaptation works in our system is my guess, but I don't know what the real reason is. I think
because when Ajit presented, he says this doesn't happen with acoustical stimuli. But you are saying it, and we also observe it all the time with cochlear implants.
Well, if it's measured in 5 dB steps acoustically, I can see why it may be hard. See, in the acoustical world, roughly 3 dB would be at least halving of loudness, or half of the loudness, I would say. So yeah, I can see why one could miss these things out in 5 dB steps. Again, I don't know whether it happens or does not happen in the acoustical world. I don't know if Ajit is on the call and maybe he can comment on it. But
it doesn't. I'm sorry, Vanaja's in the panel. I mean, in the group over there. So maybe she could add on to it, or anybody else, of course.
Yeah, yes, ma'am. Ajit sir and Vanaja ma'am both are on the panel. I will unmute Ajit sir's mic. Ajit sir, would you like to comment on this, please? You can unmute your mic, sir.
Yeah. Can you hear?
Yes, sir.
Yeah.
Thank you, Aniket, for a wonderful presentation. It's nice listening to you after a long time.
Good to hear from you too.
And madam, like regarding the acoustic ASRT, the studies have shown that the maximum difference that they see between between the clinicians, between the different types of runs, like ascending or descending, is about 2 to 2.4 dB, which is much lesser than the it's not clinically significant, because generally we use a 5 dB steps clinically, and this difference between ascending versus descending, or using reflex decay mode versus just an acoustic reflex mode, all of that is within about 2.4 decibels. So acoustically, it's not clinically significant, but probably when it comes to the current levels that he was talking, or the clinical levels that he was saying, every 1 unit of clinic, 1 unit of current level or the clinical levels, I don't know how much dB in terms of acoustics that would make. Probably it may be even hard, because it's not direct conversion from current to the decibel values.
Yeah, it's no connect. I mean, the entire dynamic range is supposed to be around 25 to 30 dB. That's what he also, from the examples Aniket gave, also it was like showing it's 30 dB. The range of that, so it's a very small range that we are actually talking about in terms of dB. But a small current level probably is bringing about a bigger change, and that's the reason we're able to see.
Or 2.4 dB difference acoustically may be a lot more difference in terms of the current units.
Yeah,
I have
think
well, I think 2.4 dB is, I mean, if I say 6 dB is roughly doubling or halving of loudness, 2.3, 2.4, let's keep it 3 dB for simplicity's sake here, is half of the loudness decrease in loudness level, right? That roughly would correspond here in terms of loudness. So here are the different factors affecting eSRT, right? One is the reflex decay itself is a noisy measurement. So one could easily be off by 10, 15, 20 clinical units in the AB and about 5 clinical units in Cochlear system before we can actually see that spike for the eSRT. Second, ascending versus descending, that causes a problem. Third is the probe frequency. I mean, if we can't measure reflex at a 226 hertz probe frequency, you have to use 670 or 1000 hertz. In theory, the reflex should happen at a slightly lower level than 226 hertz. So there are several factors at play here when I say I have measured an eSRT and I'm going to use it to map M levels. You know, one of the arguments when we had I and Rene were talking about it, and I said, look, a clinician is a slave of his experience, of his beliefs, which come from his experiences and his circumstances. If I believe in that this is my level and this is how I'm going to fit it, I will only see the part that works for me, and I'm unintentionally blinded to the part that I may be, you know, maybe I could push the patient higher. Maybe the eSRT level that I estimated is half of half, like what I'm talking about, the same thing, like 3 dB difference. 3 dB is a significant decrease in terms of loudness. Now that change in loudness doesn't affect normal hearing people because their ability to understand speech at 40 dB, 60 dB, 80 dB presentation level is similar. In cochlear implants, you take a person from 60 dB down to 40 dB in presentation level. There is a significant decrease in understanding, probably because audibility is compromised and also because loudness doesn't go linearly in cochlear implant patients. Loudness goes in a very shallow way at the lower levels, and closer to C levels or M levels, there is a rapid burst, a rapid increase in loudness. That's why the electrical dynamic range between M and C looks bigger, but the dynamic range between M and uncomfortably loud level is very small in most of the patients. So it's a very complex phenomenon that of how loudness is encoded in the cochlear implantation, and which ultimately affects where the eSRT is going to be.
Yes, sir. Thank you so much. But I think in that regard, like you were talking about, you know, the current level versus the increase in current in milliamperes, or sorry, microamperes. You were also talking about the differences between different manufacturers, like Advanced Bionics versus Cochlear. So I think that also plays a role here, if I'm not wrong, because when you are increasing by current levels or decreasing in current levels, because of the function of that growth, you might get different responses in ascending versus descending, depending on the device you use. But I don't think you mentioned about MED-EL as Asha ma'am was talking. So would you know how that growth function for MED-EL is compared to
MED-EL, whatever they show on the screen is actually microamperes. It's a very linear, straight function, right? I mean, it is microamperes is what it is. But MED-EL highly encourages you to think in terms of charge, not in terms of microamperes, because according to them, the charge is basically a multiplication of the current amplitude with the pulse duration. And so they generally encourages us to think in terms of 20 nanocoulombs or what is it, 20 QC charge, and so in terms of charge. And so that's why I kind of kept medal away, because trying to explain charge and bring it into the equation might be slightly difficult. And Asha ma'am can talk more about how charge is used in their clinic in mapping and measuring eSRT.
Oh, no, I understand. And I think in regards to what Ajit sir was talking about, the and you were also mentioning, like, the current clinical units or current levels that we change, converting that into decibels. If I'm not understanding this incorrectly, if I go according to the Stevens power law, or a simple calculation based on your growth function, that would translate roughly to about 0.176 dB. One clinical or one current level is equal to 0.176 dB in acoustics. Would I be right, or?
Well, first you'll have to convert each level into microamperes and then take it from there into dB, the 20 times locked and whatever raised that formula would be.
Yes.
I don't think it's as simple across. I mean, if you have everybody's current level in microamperes, then maybe you can convert it into dB, but I don't think clinical levels and clinical units can be readily converted into dB. That would be my guess. I mean, of course, you can build the conversion into the formula to do it, but still it would be difficult.
I just took the Cochlear, the growth function that you gave, and then I correspondingly calculated the current levels to the microampere and then put it into the equation. But I guess it will be different for advanced bionics because the growth curve is different.
And also realize that for the Cochlear software, this goes into how the architecture of the device, but for the Cochlear software, the pulse duration is not taken into account while converting from clinical levels to microamperes. For the AB software, you have to take into consideration the pulse width. That's why my mapper function had two different plots for at least two different pulse width to show that the slope changes of that mapping function depending on the pulse duration that is used to fit the patient.
Yes.
And just to add on, Imran, I think.
Yes, sir.
Yes, ma'am.
Yeah, just continue.
No, I was just a comment on what Imran just said. I think it's hard that I think it's not possible to compare between the acoustic decibel versus the decibel that you calculate using.
Exactly, that is what exactly I was going to say. Yeah. Aniket, it was a wonderful topic.
References used are completely different. The decibel is just a logarithmic ratio between two values. So anything can be converted into the decibel, whether it is current units or the intensity or the pressure. But when we talk acoustical decibels now, today, the standard reference used is 20 micropascal. So here, that is not the reference. So you directly can't convert that into the decibel and make it one. This is equivalent to so much of decibels. I think that's not possible.
Well, if we want to continue talking in that direction, the one thing that I would point is the dynamic range is what it is. To our eyes, it may appear 40, it may appear 200. But if you look at Bob Shannon's earlier work or Don Eddington's earlier work, both are fantastic papers from 1980s, 1990s, they would say that the number of loudness steps, discriminable loudness steps, are very few, somewhere between 3 to 10 or 12 loudness steps in that dynamic range there, assuming that the dynamic range is correct, which is why I was saying maybe try pushing it higher. But anyways, and that was work done on profoundly hearing impaired patients back then in the 90s when they were implanted with the device. Yeah. So even if patients who have good hearing preservation and neural survival these days, I still think the maximum number of loudness steps are probably 10, maybe 15 if you're lucky, between that electrical dynamic range. So 15 loudness steps versus whatever the delta I is. I mean, I haven't read Brian Moore in a while, but if you, what is it, 1 dB or 1.5 dB, and it changes as a function of level. So the number of loudness steps that a normal hearing individual has are just way too many as compared to what an average cochlear implant patient has. So I think if you really want to go into dB to acoustic dB to electrical dB conversion, I think we should think it in terms of about loudness steps rather than just a plain physical conversion out.
Yes, sir. Thank you so much for clarifying that. The next question, sir, is about the use of high frequency probe tone for the electrical stapedial reflex elicitation that you mentioned. So this is question regarding like babies, like in small babies like less than 6 months. As you are aware, we normally use high frequency probe tones for tympanometry and reflexes, because we presume that their system has a different resonant frequency, and there is more for example mass dominance or more of the higher resonant frequency in them. So in the babies who are less than 6 months, are you recommending that instead of 678 we use 1000 hertz because we go even higher?
Imran, the honest answer is I don't know. I have not measured eSRTs on 6 months old. I mean, try, right? If we can't measure a reflex at 226 hertz, try it at 1000 hertz. And to be honest, when I measure reflexes in a clinic, it's not that I get reflexes every single time in these children. Sometimes they come in with some middle ear fluid and things like that. And so one appointment, we don't get a reflex, but then the next appointment, we do get a reflex and things like that. So yeah, I mean, try a higher probe frequency if you can't measure reflex at 226 hertz, or for that matter, 678 hertz, I would say. I mean, logically, it would make sense because their middle ear cavities are small, so the resonant frequency is high. So using a probe frequency closer to the middle ear resonant frequency would make sense. But I don't know.
Okay, sir. So you recommend that it's more a clinically trial and error kind of thing. If you don't get it at 678, and if you are doing it for a baby, then you can go at 1000 hertz and just double check, just in case you get something.
Yeah.
So the next question is about the the live mode that you were talking about in terms of the eSRT. Would you be able to explain that, how exactly it works?
You mean the all electrode condition that I talked about?
Yes, sir. I think that's what they are asking, is the all electrode condition. How do we stimulate the electrodes in that condition?
So every time we present a burst on an electrode, right? A burst of pulses or in a biphasic pulse on an electrode, the T level is brought up to the M level behind the scenes. It happens behind the scenes, but that's how it's done, whether it's AB or cochlear metal, whatever it is. So if you want to stimulate 4 electrodes, right, just take the T level and put it to the M level or C level for those 4 electrodes, and then those will be stimulated sequentially. In the all electrode condition, if you take the AB device and if you just take the T level and bring it up to the M level, and you select a sequential speech coding strategy, then all those 15, 16 electrodes will be stimulated. They will be stimulated in the order that they would be stimulated in a speech coding strategy. That's the oscilloscope screenshot I showed you there. And if you select a paired speech coding strategy, they will be stimulated in a paired manner. So like electrode 1 and 2 will be stimulated along with electrode 9 and 10, and then so on. So if you bring the T level up to M level, what it does is make sure that every biphasic pulse that is going out on a particular electrode is stimulated at the C level. Does that answer the question?
Yes, sir. Thank you so much. So the next question is more related to the CI coding strategy that you discussed. It's up to you if you would prefer to answer it. They're asking, is the sequential coding strategy similar to time division multiplexing?
I am sorry, I don't, and I am not familiar with the term time division multiplexing. I would like to understand what that is.
I will skip that for now, sir, because it's obviously not related to emittance at this stage. But if you want to come back to it, or anybody from the panel would like to answer it, we can leave it at that. The next questions are, I think it's about 3 questions on a similar aspect. They are asking, like, once you saying that, okay, you get the eSRT thresholds, and you said that it is important to set the comfort levels or the M levels. So say if I get an eSRT threshold at, say, for example, a certain current level, now from there, how do you determine what the M level should be?
I mean, if you have measured eSRT on every single electrode or on few electrodes and then interpolated the levels for the others, I think you have to globally decrease the eSRT level by, I don't know, 5% maybe, or 10%. And then somewhere around there would be the M level or the C level for the patient. But the amount of global adjustment one needs to make varies from patient to patient. So the eSRT will give a good ballpark estimate of where the levels need to be. How much lower than that, or maybe even higher than that, one needs to go is totally dependent on the clinician. Now, one could start moving into the direction of using all electrode stimulation and measuring CRM levels. But like what Asha madam said, is in the high frequencies, she and her clinic prefers to kind of underfit the patients compared to what the eSRT thresholds are. And in the low frequencies, they more closely follow the eSRT levels. So I think there are some fitting philosophies that go along with measuring eSRTs. But one thing is sure, I think if you just measure eSRT on individual electrode, you will have to make some global adjustment lower to come closer to what would be comfortable in daily listening conditions. Not sure I answered the question, but
yes, sir. So what I understood is that there's not a like a objective figure, but roughly speaking, you just reduce it globally by 5% or whatever you get as a threshold. Would I be right?
5% was just a number. Yeah, I mean,
Okay.
I think that's what I said. Every clinician is a slave of their beliefs and circumstances, and so over time, all of us have come to understand what we think works best for us. Somebody is 5% is somebody else's 3%, and somebody else's 3% is somebody else's 1%. So that 5% was just an example.
Okay. The next question, sir, is about the case of post-cochlear implant improvement in the bone conduction sensitivity that you were talking about. Would you be able to give us some sort of understanding or reason why you think the bone conduction would have improved after the cochlear implant surgery?
I think that still is a mystery. We generally attribute that to a third window phenomena. I just don't think there is any clear understanding about how a cochlear implant electrode array placement is going to cause a third window type issue, like a superior semicircular canal descent or whatever it is. So here is how I look at it. There are some patients where the bone conduction is improving. That should point towards the third window phenomenon, but the VEMPs aren't telling us anything. There are other patients where the air conduction thresholds are decreasing. Wideband tympanometry may allow us to just scratch the surface and figure out what is going on, but we are operating through the middle ear. So I would be surprised that when we put the whole system back together after placing the electrode array, that the wideband tympanometry would ever be similar to what it was before surgery. So it is always going to change. So, and because wideband tympanometry is changing, I don't know that even wideband tympanometry is going to give us insight into what is causing this conductive hearing loss in cochlear implants. So I think this whole thing of new conductive hearing loss after cochlear implantation is a big mystery, and I don't know if we truly have the tools. I'll tell you this, just few weeks ago, we did wideband tympanometry measurements on fresh human cadaver head. Okay, so we tried to get the head as quickly as possible after death, so that the perilymph is still there and all of that is there, and tried to do a cochlear implant surgery on a human cadaver. And while we are monitoring wideband absorbance at different times, we did not see any difference in wideband absorbance during the placement of the electrode array. Now, there are lots of factors here, right? I mean, you have to have a live human and have to actually perform these measurements in the OR to understand what is happening and all of that. But maybe there are some individuals and their physiology and their anatomy that they're more prone to hearing loss, and maybe there are more prone to conductive hearing loss. So I think doing this research and having the tools to actually do all these things is extremely challenging. And I don't know that there is a clear answer of what causes that improvement in bone conduction thresholds. In fact, we even had a whole meeting here, because if the bone conduction thresholds were that good, the question was, why not just give the patient a BAHA and let them use non-natural hearing, because those low frequency, fine structure, all of that discussion that happens in the cochlear implant world, where we cannot represent fine structure through cochlear implant. Well, if those bone conduction thresholds are truly good, then the BAHA should outperform the cochlear implant. Of course, we didn't implant the BAHA and everything, the patient is using the implant. But that's the question. That was the whole debate. And it's a very stimulating debate, right? You put a piece of metal in the inner ear and the bone conduction improves. And if those are truly true bone conduction thresholds, then a BAHA should outperform a cochlear implant. Although I don't think anybody's going to do a BAHA surgery on top of a cochlear implant surgery, but something to think about.
Now you can just put BCA and from the external and see did the person improve with the implant off?
Yes, ma'am. We actually, the BAHA, the external, I don't know what is the band, the BAHA band, soft band, yeah. Actually, BAHA in our section is done in hearing aid, so I'm sorry about that, not remembering the terminology here. But so we did try that, and I mean, it's a child, and just we didn't do any speech discrimination or anything, but just behaviorally, the patient said, "Oh, that's better than the electrical stimulus." I would take this with a grain of salt, but yeah.
Okay.
No, we also measured electrocochleography, because sometimes, you know, bone conduction can be vibrotactile and all of that. So we said, okay, if we can measure bone conduction ECOG, and we have a published article on it, then it is what it is. And we truly find a difference between the threshold for bone conduction ECOG and air conduction ECOG in these patients. So that airborne gap is a true airborne gap after implantation.
Thank you, sir, for explaining that question. Now, the next question, sir, is regarding the, like how you talked about, if we really need to understand what's going on in this regard of, like how the bone conduction or the air conduction changes. Like single side deaf patient, we can study the eSRT. Could you elaborate on what were you sort of looking at in terms of further research and what the clinical expectations should be?
Okay, so that point was not in relation to conductive hearing loss. Remember, we just had this discussion about we sometimes cannot measure a reflex at 226 hertz. I mean, the electrical reflex at 226 hertz, but we can measure it at 678 hertz and 1000 hertz. Such an example does not exist in the acoustical world, where, and Ajit, please correct me if I'm wrong, is that if you can measure a reflex at 1000 hertz, you will always be able to measure a reflex at 226 hertz. The reflex at 226 hertz might be at, let's say, 90 dB, and the reflex at 1000 hertz may be at 80 dB. That's just an example, by the way. It's not 10 dB, but that's just to put the things in perspective. And
No,
so,
Aniket.
yeah,
Yeah, Aniket and Vanaja here. It was an excellent lecture.
thank you.
And we do see in infants, we don't see reflexes at 226 hertz, but we do see reflex at 1000 hertz, acoustic reflexes. I mean, if I do on newborn babies or less than 2 months, I do see reflexes at 1000 hertz, but I do not get reflexes at 226 hertz. So such a phenomenon is seen in acoustical stimuli also. I think, I'm sure.
Yep, go ahead, ma'am.
No, that's it. I just wanted to say that, saying that it is seen in acoustical. Actually, Devi is there, then she can add on, I think.
Okay. Well, thanks for letting me know that is seen in infants. Like I said, I don't work with infants, and I haven't done routine audiometry in infants in a long time. At least I think, to the best of my knowledge, such a phenomenon is not reported in adults, and most of the eSRT work that I talked about, or the pro-frequency effect that we talked about, is in adult patients. And one of the things that everybody has said is, we just sometimes shy away from pushing the current high enough. We think the patient is saying us, oh, that's too loud, and that is actually too loud. Present the same stimulus for 30 seconds and see if the loudness changes. It changes very rapidly in cochlear. There's a great paper by Fang Gang in terms of how the electrical stimulus adapts. What is level 6 at the onset, when I soon start presenting, becomes level 4 over a span of 1 or 2 minutes. So maybe at 226 hertz, we need a higher electrical stimulation level, and we aren't delivering it. Now, I have tried to push it as high as I can, and I still cannot measure reflexes sometimes at 226 hertz, and can measure reflex at 1000 hertz. To answer this question, is it the stimulation level, or is it just truly something in the middle ear that is preventing us from measuring a reflex from 226 hertz? We can study this phenomenon in SSD patients. And what do I mean by that? SSD patients have normal hearing on one side and a cochlear implant on the other ear. Okay. So in a normal hearing ear, when we present a stimulus and measure a reflex at 226 hertz in the implanted ear, we should see a reflex, right? I mean, we have a normal ear, we are presenting, let's say, 1000 hertz at 90 dB, 100 dB SPL, and we are measuring a reflex in the implanted ear at 226 hertz. I think we'll see a reflex. I'll be surprised if we don't. And then, or maybe it's the other way around. I'll be surprised if we see a reflex for the acoustical stimulus and then not see a reflex for the electrical stimulus. So contralaterally, if I can establish that I can measure a reflex at 226 hertz in the implanted ear using an acoustic stimulus, then when I present the electrical stimulus and measure the reflex in the implanted ear, I should be able to see a reflex. If I am not seeing a reflex for 226 hertz for an electrical stimulus, it absolutely is saying that our stimulus is not loud enough. I don't know, is that clear?
Aniket here, I would think it's more related to the mid-ear characteristics probably. Have you really looked into the resonant frequency when you got reflexes at 226 hertz for some adults and you did not get for some other adults? Did you look into the resonant frequency or the mid-ear wideband absorbance or multi-component tympanometry between these two groups? Maybe that may throw some light on it.
We did not find a correlation between middle ear resonance and patient whom we got a reflex at 226 hertz, and in patients whom we did not get a reflex at 226 hertz.
You didn't get?
Ma'am, I'm totally with you that we will not. If we get a acoustical reflex at 226 hertz, we will also get an electrical reflex at 226 hertz. And if we, for whatever reason, are not able to get an electrical reflex at 226 hertz, I think everything is then pointing to the level. The level is just not loud enough. Because if acoustically we can measure, if for an acoustical stimulus we can measure a reflex, we should be able to measure it for an electrical stimulus. I mean,
can I butt in? Okay, I'm just thinking for an acoustic stimulus, when you're giving, but you're talking of contra, right?
Yeah.
Yeah, talking of contra, but definitely for electrical stimulus, there is a difference. I think we don't go so kind of stimulation is different in an electrical stimulus. But in ipsilatery, as Vanaja said, there is a difference after implantation. They they tend to get a lesser compliance after implantation. But and if you're giving an acoustic stimulus in a regular ear, then I think the 220 hertz tone and this maybe they add up in some way. But electrical, yes, there are some issues.
Hello, can you hear me, please?
Yes.
Yes, sir, we can hear you.
Dr. Aniket, thank you very much. Really, it's a great presentation, very informative and very stimulating. My name is Alfarghal Mohammad, and thanks for the invitation. Just my question, I find it very interesting to know that it's more easier to get electrical stability reflexes with 1000 hertz probe tone. So I'm not aware of literature which studied well the acoustic reflex with 1000 probe tone in acoustic. Because the concept in my mind that its reflexes have a better chance to be recorded with 226 hertz probe tone. This is in the normal acoustic population. So if we have enough data, I'm not aware really of research and data about the acoustic reflex recorded by 1000 hertz probe tone. The idea in my brain that it's not that good, and you have a better chance to record the acoustic reflex by 226 hertz, because this could explain well this interesting finding about the electrical stability reflex. At least we understand the mechanism why it's more easier to be recorded with 1000 hertz. So we can just use the acoustic model to help us to understand the electrical model.
Anybody from the, we did this research with Animesh sir long time ago. And in adults, we were able to measure reflexes at 226 hertz, 678 and 1000 hertz all the time, normal hearing adults. And if I remember this data correctly, this is about 20 years ago. So I vaguely remember, but if I remember the data correctly, the 1000 hertz probe tone almost always elicited a reflex at a lower level than the 226 hertz probe. And I think it was the same for 678 hertz also, that the probe, that the reflex threshold was slightly lower than the reflex threshold obtained at 226 hertz. I think there is some work done here by Vishakha Rahul on different probe frequencies. And then a lot of work was done in the 1980s, the Margolis and that group, and I'm blanking on some of the names who did some pioneering work in the 1980s on comparing different probe frequencies. And maybe Ajit, you can comment on how the 1000 hertz is slightly more sensitive than 226 hertz. Sir, I think what you were pointing to, that the 1000 hertz is not good, with the limited knowledge I have, is probably because 1000 hertz is not a very stable probe frequency. It has lots of artifacts, and if you look at in the reflex decay mode, it's not a very, it's moving all over the place versus a 226 hertz probe, and that might make it difficult to measure a reflex with 1000 hertz. That would be my best guess at this point.
Thank you. Thank you.
Just to add on to Aniket, as he said, like there's ample of research, especially done in like late 80s and early 90s using 1000 hertz probe tone, and almost always the 1000 hertz probe tone gives a slightly lower reflex thresholds than the 226 hertz. And the 1000 Hz probe tone is kind of a standard probe tone when we do reflexes in neonates and infants. Even in adults, it results in a slightly lower reflex threshold. The only issue, as Aniket pointed out, with the 1000 Hz probe tone is the admittance is not stable. You really can't maintain a stable admittance for a longer time to view the reflexes clearly, and primarily because of the artifacts, a lot of people don't tend to use the 1000 Hertz probe tone for reflexes.
I have a discussion in the United States a few years ago with like Professor Lisa Hunter, and with a group for the neonatal hearing screening program. And what I did, and I have been doing some training with them, and what I understood that even for the neonates, we do the tympanometry with 1000 hertz, but when it comes to the external canal volume and the reflex, we go back for the 226 hertz probe tone. So we will ask Professor Lisa Hunter.
So I think one of the big questions is why in neonates, and this is from long time ago, so I'll try to think through this and say is that in neonates the skin can vibrate at the frequency of the probe tone, and it can be interpreted as a reflex. Ajit, is that correct?
Yeah.
So that's why sometimes you can see a reflex at 1000 hertz in a neonate, but not at 226. Is that true, Ajit? I remember reading this a while ago.
That is a kind of artifact people talk about at 1000 hertz. That is one of the kind of the artifact that people talk about in neonates. But of late, I think most of the protocols tell us to use 1000 hertz probe tone for reflexes in neonates, because the reflexes are generally present in 1000 hertz, and most of the time it could be absent in 226 hertz, especially in neonates.
I totally agree with Ajit on that. We have done a study where we have seen we have got 1000 reflexes at 1000 hertz, but not at 226 hertz when we did a study on newborns. Or definitely, so definitely 1000 hertz is recommended for checking reflexes in newborns.
Thank you.
So if I may to draw an analogy between what Vanaja ma'am and Ajit is saying here about, so one thing is in neonates, the middle ear cavity must be small, the resonant frequency must be high. So using a probe frequency closer to the resonant frequency probably gives a better chance of eliciting a reflex. And if I may draw the parallel between cochlear implant patients, in theory, what is happening is we are putting a big electrode array in the cochlea and basically interfering with the piston mechanism. Like when the oval window is pushed in, the round window should be pushed out. But over time, the round window undergoes a lot of fibrosis. So even though there is no ossification of the stapes foot plate, the middle ear of an cochlear implant patient is behaving like an otosclerotic ear. That is, it is more stiff because of all the fibrosis and all the round window interference we have created. And because it's more stiff now, we may be able to elicit a reflex at 1000 hertz and not at 226 hertz. Although the middle ear resonant frequency doesn't confirm that the resonant frequency always goes up quite a bit higher. But again, the resonant frequency is just an estimate of the model of what is mass and what is stiffness. I don't think there is anything called absolute resonant frequency. So the resonant frequency, and I think the resonant frequency is quite variable. In fact, sometimes I get a resonant frequency of 800 hertz and then take the probe out of the ear and put the probe in next time, and I get a resonant frequency of 600 hertz. So I've easily seen variations of 80, 90 hertz in resonant frequency. So I don't know if I can use resonant frequency as a metric of how stiff the system is. Maybe wide changes in wideband absorbance, which are all pointing to a relatively stiffer auditory system after cochlear implantation, may tell us why 1000 hertz has a better chance of eliciting a reflex in an implanted ear than the 226 hertz probe.
And also, the cochlea contributes to the resistance part of the middle ear. So putting a cochlear implant would alter the resistance part of the middle ear, and this, I don't know in what way, might probably contribute to the admittance in some way and make 1000 hertz more, or change its resonance frequency and make it more sensitive towards 1000 hertz frequency might become more sensitive for the reflexes, primarily because the resistance portion of the cochlea is altered because you put a metal implant in the cochlea.
Until about Ajit, few weeks ago, I was firmly behind that theory, but then our experience in the cadavers did not show any change. So that's the reason I didn't bring it up. But your point is very well taken. I think there is no doubt that we have put in a metal wire in the cochlea now, so it has to do something to the stapes more. It has to offer more resistance to the movement of the stapes.
Thank you all for a fantastic discussion on this point. Aniket, sir, just for the benefit of our listeners, there is some confusion now in regards to this discussion. Like when you said that, okay, in an implanted ear, the ear is more stiffness dominant, and therefore there is more chances of getting a reflex at a higher frequency. But then on the other hand, we were discussing that in an infant, the middle ear is mass dominant, and therefore there is a higher chance of eliciting a reflex at a higher frequency. Would you be able to just clarify this fact, because it's contradicting?
Man, Ajit might be the best person. I thought in infants the middle ear is smaller, so the resonant frequency is higher, which would indicate that.
No, the resonance frequency is lower in infants. It's more mass dominated. Resonance frequency is lower.
Oh, okay. Maybe I completely. I thought the middle ear cavity should be smaller than the adult middle ear cavity. Is that not correct?
I was just remembering, maybe the Srividya can throw some light, because in some she showed 2 resonant peaks. So is that something that happens in implanted people?
Yes, I will answer on behalf of Srividya. Yes, when we did a wideband absorbance testing with the infant, we noted 2 absorbance frequencies. So what we noted in children, in infants, there's a low resonance frequency, but in fact, it's not a mid-ear resonance, it's a resonance of the external ear canal. They have a resonance frequency around 1000 hertz, mid-ear resonance. The lower resonance frequency, which is picked up by the instrument, is not exactly mid-ear resonance, it's a resonance of the ear canal. And this has been shown in other studies too.
If the resonance frequency is higher, wouldn't it be a stiffness dominated system?
Resonance frequencies, the average resonance frequency, they fall within the normative range. But if you take a mean, it's a higher in infant, then become a little lower in children, then again lower in adults, if we take median values.
Right, sir. So I would have assumed, and maybe I've gotten my physics completely backwards here, but a higher resonant frequency would indicate a middle ear that is more stiffness dominated. I mean, a tympanic membrane that is more stiff rather than the middle ear. Or no?
The reason given for the lower resonance frequency in infant is not the measuring the middle ear resonance in wideband, it's the measurement of the ear canal resonance. Around 350-400 hertz.
Right. So if the true middle ear resonant frequency in an infant is higher than the middle ear resonant frequency of children and followed by middle ear resonant frequency of adults, yes, I would have assumed that the middle ear of an infant would be more stiffness dominated, would be more stiff. The whole system would be more stiff than the middle ear of an adult. And that would explain why the resonant frequency is slightly higher. The true middle ear resonant frequency of an infant would be slightly higher than the resonant frequency of an adult.
Yeah, that's true. That's what we observed in our studies. using the another technical frequency impedance measurements.
So
Aniket,
now I am confused now. Sorry.
no, Aniket, you're true that if resonant frequency is higher, it is stiffness dominated, yes. But now the writer is talking of saying when you're measuring lower resonant frequency, it is a ear canal resonance which is playing. But when you're doing impedance or you're checking acoustic reflexes, or when you're doing tympanometry using a routine method, we are not really measuring a true mid-ear resonant frequency, right? It is affected by your ear canal resonance and everything. So I don't know if it can be very clearly attributed to the.
That is true. The resonance frequency, what we say, the mid-ear can have several resonance frequencies. It depends on the conditions. So if you take the earlier studies, we say resonance frequency, say oscillator chain, they usually fall between 1,500 to 2,000 hertz. So it's a mid-ear resonance. So it can vary between.
I guess so. I don't know, to be honest. I'm not a middle ear expert. I'm just using this to fit our patients and understand what's going on with their middle ear. But thank you for the discussion and the clarification.
Thank you, sir. We are just out of time for the other questions. There are a few questions. Is that okay if I just email them to you, and if you have some time at some point, you can answer them, and then we can distribute amongst the people who have asked them?
Sure.
That will be great. We just have like 2 minutes. If the panelists want to contribute anything before we wrap this up. Any comments from the panelists? Anything?
Exciting, very exciting.
Hey, Imran, can you tell me
Excellent talk and
on the
excellent
panel?
discussion.
Ajit, can you tell me who all are on the panel? I don't know. Did I miss that when you introduced the panel, or?
I will introduce the panel, sir, again. So right now on the panel, we have Dr. Ajit, we have Dr. Alfarghal Mohammad, we have Dr. Madhuri Gore, we have Dr. Vanaja, and we have Dr. Venkatesh Aithal on the panel at this stage, sir.
Thank you, Imran, and thank you, panelists, for all the questions and interesting comments and discussion.
Thank you so much, sir, for an excellent talk. I'm sure that the listeners have a very strong and excellent take-home message from this. I'm sure everybody got something out of your presentation. It was a very, very, comprehensive and also a very lucid explanation of eSRTs and its importance in cochlear implant mapping. I'm very, very grateful to you, thankful to you to help us again in this new endeavor, new webinar series on emittance audiometry. And I'm sure you must be tired now. I've gotten you to wake up early for this. Yeah, thank you so much again. Thank you, panelists, for helping us again with this endeavor. It was a very, very nice, fruitful discussion. And I'm sure that a lot of people were engaged to it.
So thank you. Thanks a lot for giving me an opportunity, and thank you everybody for participating and your comments and questions.
Thank you, Aniket. Thank you, all the panel members. Thank you, all the audience. Thank you, ISHA. I'm sorry, but I have to close. There's no much time for me. Just 1 more minute for me. Is that okay?
Okay, thank you very much, Aniket. I will write to you also. I'm Madhuri Gore, okay.
Thank you.
Thanks.
Can I close? Thank you.
Yes, ma'am.